Neonatal hypoglycemia. It's probably one of the most common metabolic hurdles we face in the NICU and the newborn nursery. But for something so common, it's still packed with clinical debate and nuance. So today, we're going to roll up our sleeves and dive deep, from the basic pathophysiology all the way to what we actually do at the bedside.
And that brings us right to the million-dollar question. What number are we actually treating? What's the real threshold? Well, the tough part is there's no single magic number. No one glucose value that universally predicts a bad outcome. And it's that gray area, that ambiguity, that makes a solid grasp of the physiology and the guidelines so absolutely critical in our day-to-day practice. So let's look at how this plays out. You've really got two different ball games here. For our routine screening of those at-risk but asymptomatic babies, the AAP gives us these transitional thresholds that change with time. But what if you suspect something more is going on, something persistent? That's when the Pediatric Endocrine Society guidelines kick in, and you can see their targets are much, much higher. It's all about aggressive neuroprotection. The bottom line is, your goal completely depends on the context. So here's our game plan. We'll start by tackling that elusive definition. Then we'll get into the incredible postnatal metabolic switch, unpack the different causes, talk about the all-important critical sample, cover modern management, and finally, wrap up with what's truly at stake, the baby's neurodevelopmental future. First up, let's talk about that definition. But to really get it, we have to start with the normal, expected drop in glucose that happens right after birth, the physiological nadir. So every single healthy term baby goes through this. Their blood sugar dips sometime in that first hour or so of life. But here's the key. It then comes back up all on its own. This normal, spontaneous recovery is the entire reason our treatment thresholds are time-based and not just one static number. It's all part of the plan. Okay, building on that, let's look at the absolutely dramatic metabolic flip that happens the second that umbilical cord is clamped.
Think about it. In utero, life is easy. The baby's getting a constant 24/7 glucose infusion from mom. But at birth, that supply line is cut instantly. And that triggers this incredible hormonal cascade. You get a massive surge of catecholamines and glucagon while insulin levels plummet. This is what flips the switch on the baby's own glucose factory, first burning through stored glycogen and then kicking off gluconeogenesis.
Now, why is this switch so important, so time critical? Because the newborn brain is an absolute glucose monster. I mean, look at this. It's hogging up to 80% of the body's entire glucose supply. It has to have glucose to function, which makes it incredibly vulnerable if that fuel supply gets disrupted for any reason. So when that fuel supply is disrupted, what's going on underneath? Well, we can really split the causes into two big buckets. The common, temporary causes that are part of adapting to life, and the rarer but much more serious, persistent causes. Most of what we see is transient. These are the cases that resolve in a few days, usually tied to things like low fuel stores or a temporary state of too much insulin. But when that hypoglycemia just won't go away or keeps coming back, that is a huge red flag. It points toward a deeper issue, something genetic, endocrine, or metabolic that needs a full court press investigation. And inside that transient bucket, you've got our usual suspects, right? The infant of a diabetic mother, whose own pancreas has been working overtime. The IUGR baby, who was born with a nearly empty gas tank. And really any baby who's been through a lot of stress. Think asphyxia, sepsis, or hypothermia. Because stress just burns through glucose reserves like crazy. These are the babies we're all screening. Now, when the hypoglycemia sticks around, our differential has to get a lot broader. The number one cause here is congenital hyperinsulinism, or CHI. But you also have to think about endocrine problems, like a lack of cortisol or growth hormone. And then there's the whole world of inborn errors of metabolism, things that mess up glycogen storage or the ability to burn fat for fuel. All right, let's switch gears to diagnosis. How do we get from a vague clinical suspicion to a concrete answer? Well, it starts with recognizing the signs, which, as we all know, can be frustratingly nonspecific. You look at this list, jitteriness, poor feeding, lethargy, none of these scream hypoglycemia exclusively. It could just as easily be sepsis, or an electrolyte imbalance, or a neurologic issue. And that clinical overlap is exactly why we have to keep a super high index of suspicion and a really low threshold for checking a glucose on any baby that just doesn't seem right. Okay, listen up. If you take one clinical pearl from our time today, this is it. The critical sample. It is, without a doubt, the single most important diagnostic step for persistent hypoglycemia. But the key is it has to be drawn during the low. It's a metabolic snapshot. Think about it.
A low glucose with a sky-high insulin level and no ketones, that's not just a clue, that's practically a confession of hyperinsulinism. This sample is our Rosetta Stone. It deciphers the whole problem for us. So now that we have a diagnosis, what do we do about it? Let's talk management. The key here is a stepwise approach, starting with the least invasive but effective options first. The algorithm is pretty logical. Of course, we start with early feeding. If that's not enough and the sugar is low, buccal 40% dextrose gel has become a real game changer. It's now a first-line therapy, and it's proven to keep babies out of the NICU. We only escalate to an IV bolus and then a continuous drip if the gel doesn't work, or, of course, if the baby is symptomatic right from the get-go. And the dose for that first hit of glucose is a number you just have to know: 200 milligrams per kilogram. That works out to a half a mil per kilo of the 40% dextrose gel, or 2 mils per kilo if you're giving D10W through an IV.
Now, for the tough cases, for persistent hyperinsulinism, we have to bring out the bigger guns. First line is usually a drug called diazoxide. If that doesn't work, we might move to octreotide. And in an emergency, a glucagon infusion can be a lifesaver. For some of these babies, the answer is surgery. And that's where incredible imaging like an 18F-DOPA PET scan comes in, helping surgeons see if they can just remove a small focal lesion or if they're dealing with diffuse disease that requires a much bigger operation. And all of this, all of our vigilance and aggressive treatment, it brings us to our final and, frankly, our most important section. What's at stake? It's all about protecting that developing brain. This, right here, nails it. This is why hyperinsulinemic hypoglycemia is so dangerous. It creates what you could call a dual fuel crisis. The high insulin doesn't just tank the blood sugar, it also shuts down the body's ability to make ketones. So the brain is robbed of its main fuel, glucose, and its crucial backup fuel, ketones, at the exact same time. It's a perfect storm for neurologic injury. And when that injury happens, we can actually see it. The MRI often shows a classic pattern of white matter damage, hitting the back of the brain, the occipital and parietal regions the hardest. This is the tangible, visible evidence of what we're fighting so hard to prevent. So we're left with this fundamental balancing act that we walk every single day. We know the stakes are incredibly high. So how do we find that sweet spot? How do we avoid over-medicalizing what's often a normal transition, while at the same time making absolutely sure that no infant suffers a preventable brain injury on our watch? There's no easy answer, but finding that balance is the art and science of what we do.